Hi, everyone. Thank you so much for joining us here today at our Children's Hearing Health live stream. My name is Jay. I am the Associate Director of Marketing here at the House Institute Foundation, and I'm so excited to be with you here today. Before we get started, I wanted to tell you about exciting news that the House Institute Foundation has coming up. Opening this summer, 2022, is the House Children's Hearing Center. It is going to be the only comprehensive hearing center devoted to the evaluation, diagnosis, and treatment of the full spectrum of hearing conditions in children from birth to 18 years. And that's happening this summer, and we are so excited. If you want to learn more about this grand opening, you can click the link in the bio, in the description box below, and you can go and type in your email address, your phone number, your information, and somebody from the House Children's Hearing Center will contact you when we're getting ready to open. Thank you so much. We're about to move into the question and answer portion, what you guys all came here for. But first, we're going to go dark for just like 5 seconds so that we could switch. I do want you guys to know that unfortunately Dr. Luxford could not make it today, so it will be me and Dr. Peng answering your questions. Just give us a quick 30 seconds and Dr. Peng will be right with us. Can you text Aaron?
Mask on or
off?
Okay, so let's bring you all up.
okay.
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 If you kind of go to the side, so you can like look at each other if you want.
Okay.
Sometimes.
If we're on the screen.
Cool.
Yes, like that. Okay. Yeah, so the closer you are to the mic, the better.
Okay, good. Yeah, no problem.
Great. Thanks. I think we should go in a bit, Aaron. You think we're too out, maybe?
I think like that.
Okay. Yeah.
Perfect.
Okay.
Great.
Hello.
Thank you for joining us.
Yeah, thanks for having me and thanks for tuning in.
Fantastic. We've already gotten so many questions in the chat from people, so we're just going to jump right in. So this first question is swimming in ear tubes for toddlers. What we need to do to make sure water doesn't get in the ears.
Yes. So in general, if swimming with an ear tube is actually okay. That's the latest American Academy of Otolaryngology guidelines, our national society for ENTs in the United States. It's actually okay to swim if somebody has ear tubes in. It's a different story if you have a tympanic membrane perforation or a hole in the eardrum. In those cases, patients have to be very careful not to let water enter. But if there's...
Sorry, Dr. Peng, 1 second. It seems like the sound quality is having a little bit of issue. Maybe we move the mic a little bit closer to you. Is that better?
Test, test, test. Is that any better? Let's try this.
Is that better on your end?
Should be fine, yeah.
Okay.
Okay, let's try that again. I was saying that in most cases, for patients with, I just saw
Oh no.
a little.
A little better.
Do you think it's a microphone issue or Audrey?
It's not. They're saying that they don't think it's the mic. Do you have anything on your end that's showing? Are you guys? Am I coming through okay?
Test, test, test.
Hello, hello.
I'm adjusting some things, but I don't really know what would be wrong. It seems fine.
Maybe I need to speak louder.
Yeah,
I think you're...
The closer to the mic you are, probably the better.
Okay.
Okay.
Well, let's try this and let's see. And so what we were saying was that basically for patients with ear tubes, you actually don't have to take any special precautions if you're swimming in a chlorinated pool, for example. But if somebody has a hole in their eardrums, that's a totally different story. You have to be very careful not to let water go in. In terms of what we need to do to make sure water doesn't get in the ears, if your kid or toddler has ear tubes and every time they swim, they feel super uncomfortable, I think it's totally a good idea to put in earplugs. You can either buy kid-sized earplugs, just commercially available. There are a bunch available even online or in the drugstore. You can try using an adult earplug and see if that works. Some people really like the white silicone putty that you can mold and put in what we call the concha, which is the cartilage part of the ear here leading to the ear hole. And they even sell other plugs such as Doc's Pro plugs and many of the earplugs that have that same shape that once again wedge into that cartilage portion. So those are all options for basically protecting ears from water if it's necessary.
And for toddlers with ear tubes, how many times can an ear tube surgery be done?
Yes, I don't know if there's a definite maximum number of times that it can be done. I will say that many of our patients will have ear tubes performed maybe even 4 or 5 times before they reach puberty. And some children with other medical conditions, including cleft palate or occasionally Down syndrome, might need ear tubes even more frequently than that. And the eardrums are by and large able to withstand that. So I don't know if there's a true maximum in terms of how many times we can put those in.
Okay, great to know. And we have a question here from someone who is deaf themselves, and is currently expecting a baby next month and are trying to prepare for the possibility of the baby being deaf.
Yeah.
So what is the current practice for sensory neural hearing loss for newborns?
I think one of the main things that we do is we screen for hearing loss so that we know if a child has hearing loss right after they're born. There are a variety of ways to perform screening, but it's, as many of you know, it's almost a part of the hospital routine. A technician or an audiologist will come in and perform the testing, and sometimes you might not even realize that that's actually what they're testing for. So the first thing is diagnosis, figuring out if there's a hearing loss. If there is a hearing loss, then there's the question of, should we go ahead and proceed with hearing aids once the child reaches, maybe a few months of age, or are we going to usually get a better hearing test when they're a little bit older, again around a few months of age, so we know what their true hearing levels are. I know that some parents and some families who have hearing loss that runs in the family may even choose not to go that route, to have hearing rehabilitation in the form of hearing aids or a cochlear implant. And I think that is a reasonable decision that the family can make as long as everybody is informed. So I think those especially are some of the issues to consider when a child is suspected to have hearing loss in a family with a known hearing loss history.
Fantastic. Thank you. Another question we have here is what are the chances of losing hearing with EVA and flying in toddlers, and what can be done?
Yes.
And before you answer that question, there might be people in the chat who don't know what EVA is, like myself. So could you explain that first and then go into the answer?
EVA stands for enlarged vestibular aqueduct, and it is an abnormality in the bone of the inner ear that is associated with hearing loss. It can be genetic in nature, but it can also arise in patients where there's no family history of hearing loss or of EVA. I think the danger with EVA is that any pressure change, including flying or even scuba diving, for example, or even head trauma, those can all potentially be associated with worsened hearing after exposure to that pressure incident or that head trauma. But it's difficult to quantify exactly what is the chance that a toddler with EVA will get hearing loss after they fly. I do think that just from seeing patients, the chance of that happening is low. It's already quite low. But if we want to minimize that chance further, sometimes we would consider putting in a pressure equalization tube, like an ear tube in the eardrum, to equalize the pressure while flying, so that the ear isn't subjected to any pressure waves or high pressure. So I think that could be something that can be considered. If somebody has a specific question about that, definitely ask your physician, express your concerns, and then we can talk about if that is something that should be considered for that particular case.
Fantastic. Thank you. Someone had a boyfriend in an accident, and the boyfriend lost hearing from one ear, and they're wondering if it's possible to still recover if he gets an implant.
Sure, yeah. It depends on the type of hearing loss. So sometimes after an accident, patients will have what we call a conductive hearing loss. I know many of you on this video will be familiar with that, but that means that the vibrations aren't getting through from the eardrum into the inner ear that senses sound. Whereas other patients after an accident might have what we call a sensory neural loss, which means the nerve isn't working well. If the nerve isn't working well, then it depends on how poorly the nerve is working in terms of, does that patient need a hearing aid, or do they need something more advanced such as a cochlear implant? If it's a conductive problem, which is the first possibility that I just mentioned, sometimes patients can benefit from surgery where we put in a different type of implant. Not a cochlear implant, but an implant that's like a prosthesis, a fake hearing bone, to restore the vibrations from the eardrum going into the inner ear. So I think it's important for the person in question to get tested by an audiologist to get formal hearing testing, and then talk to a physician. Is this a conductive loss, or is it a sensory neural loss, like a nerve loss? And what should be done about that level of hearing loss?
So for a sensory neural loss, a cochlear implant is indicated?
If it's severe enough, many patients with a sensory neural loss, that's severe enough, can be candidates for a cochlear implant. There are other things we take into account too, especially in children. The status of the other ear is important, like how well does the other ear hear? Does the patient have a good support system to be able to thrive after getting an implant, for example? So there are lots of considerations, but yes, exactly. You're right in short that if somebody has a severe to profound sensorineural hearing loss, especially in both ears, that's when we start thinking about cochlear implants.
Okay, fantastic. Thank you. The next question here is, does any child with severe to profound hearing loss benefit from a cochlear implant more than a hearing aid? And maybe you could talk a little bit about candidacy and how you decide, or how a family would decide whether a child gets a cochlear implant or a hearing aid.
I think one of the most important things to consider is if a child is progressing along the hearing and language milestones while wearing their current hearing amplification, meaning their current hearing aid or their current system for hearing amplification. And that's one of the main things that we use. There are specialized tests that we use for adults, but a lot of those tests are less meaningful when we're talking about children, just because we can't do complicated sentence testing and that sort of thing in kids as easily. So we really depend a lot on the audiologist's input, as well as the other affiliated staff members. These might include an education specialist, a speech and language pathologist, among other professionals, to tell us, how is the kid doing with their hearing aids, and is it time to start considering a cochlear implant? So it's to answer that question, a child with severe to profound hearing loss, will they do better with a cochlear implant versus a hearing aid? It's difficult to say. It depends on how bad the hearing is and how well the kid is doing with the hearing aid. If a child has that type of hearing loss and is wearing hearing aids but is meeting their language milestones, then that's great. And often we'll say, it's working, let's not do anything more invasive such as a cochlear implant, and let's continue with hearing aids. But I think the important thing is also to find an audiologist that you like and keep on seeing them. And we're happy to help if you're in the area, but I think establishing that relationship is very important.
And as Dr. Peng is talking about kind of all of the different people that go into creating a care plan for somebody with hearing loss, like a speech language pathologist, an audiologist, a neurotologist, that's why we created the House Children's Hearing Center as a center that is a full spectrum. So we can help take your child from, first diagnosis to care plan, seeing them through to the end, because all of those different moving pieces, it's really important that they're kind of interconnected and you kind of understand all the different moving pieces, correct?
Yeah,
that
absolutely.
goes
Yeah.
into
I would say
having
so.
a child.
Yeah, I think that's Jay, this may even have predated many of the employees at the foundation, but we used to have a children's center. In fact, the House Children's Center was one of the earliest ones in California, if not the earliest. I don't know which year it was started, but we used to see a lot of children for a variety of conditions, and then we started doing cochlear implants for children, and that was probably back in the 80s, 90s. I don't know the exact time because I wasn't practicing then, but I've read the history about that sort of thing.
Yes.
And so it's sort of evolved. And so what you're referring to is basically the latest iteration of us opening up again. So we're excited about that, to continue to be able to serve kids and their families.
Fantastic. So kind of continuing on this conversation about cochlear implants, the question is posed, how early can a newborn get a cochlear implant?
It depends on the reason for hearing loss. Some children unluckily get meningitis when they are very young, and meningitis is associated with hearing loss, where implantation has to be done early, even probably around 6 months of age, or definitely before 1 year of age, if the meningitis and hearing loss preceded that. Other than that, often we wait until patients are a little older, so at least 1 year of age, before we consider them for a cochlear implant. We definitely want to get them implanted early, though, so that they can hear all the sounds they need to while they're developing language. And I think the trend is moving earlier. So I think more and more physicians around the country are implanting kids younger than a year of age, depending on the situation, depending on the urgency, taking into account if there's meningitis, if there are any other factors. Basically thinking that the earlier we can get sound for an infant or a toddler, the better. So I think the short answer to that question is it depends a lot, but before a year of age is commonly done now.
Fantastic. This question is related to a toddler with NF2, and it is, are there similar concerns with flying and pressure changes that were discussed with EVA for a toddler with NF2?
No. We do think that NF2 patients will not have the same pressure challenge issues. It is very rare, of course, for a toddler to be diagnosed with NF2. The typical age of diagnosis of NF2 is usually around a young adulthood. So it's very unusual, but it's not unheard of. So if you do know a toddler with NF2, usually, fortunately, there are not those same concerns with hearing deterioration with flying or trauma.
Fantastic. Thank you. The pressure equalizing tubes for 5-year-olds, can it be done while they are awake?
Generally not. At least in the United States, the standard practice is to have patients be monitored by an anesthesiologist, so that the anesthesiologist is, monitoring the vital signs and giving the patient appropriate medications, so that they're super sleepy and they don't feel anything and they don't remember anything. We want it to be, as painless as possible, as the least traumatic as possible for the kids. So no, we don't do it with the kids awake.
Fantastic. Thank you. And I believe we have some questions from our live audience.
Great.
Okay, thanks. Some more questions coming in. How do pediatric hearing aids differ from adult hearing aids?
Fundamentally, they're the same. They're devices that are fit to the patient's hearing loss. I think there are some logistical issues to consider. The first is that kids are super active. So kids run around a lot and sometimes the hearing aids fall off. So we need to make sure they're fit really well. Usually that means that there is a mold that goes into the ear. So the audiologist will take an impression of the ear canal and of this cartilage area, the concha, and the hearing aid will be fit to that and adjusted and shaped appropriately so that it really sits well, and then it usually will loop behind the ear too. So in the pediatric population, we see fewer hearing aids that go straight in the ear canal. Because they're smaller, they can get lost more easily and they don't fit as well. And I think it's also a little bit easier for kids who might not have all the dexterity that like an adult might have to put the hearing aids in. Fundamentally though, they're very similar. They take the sounds in through a microphone, they play the sounds out, tailored to the patient's hearing loss, and in that sense they're identical to hearing aids used by adults.
Fantastic. And what about the growing process? So, kids kind of spring up like beans.
Yeah.
So what like I'm assuming that also applies to the ears.
Yeah.
So kind of how often could somebody expect that a child would change their hearing aids?
Yes, I think so. Certain changes can be done in terms of lengthening the tubing or altering the angle that's curling around the ear, and that will be done by the audiologist, and that might be necessary, for example, if a kid is growing really fast. But in terms of changing the actual device, usually a change every few years may be necessary, or if a device breaks, then maybe sooner than that. But fortunately, we don't have to change out the whole hearing aid as the kid grows. We simply change out sort of the parts that can be swapped out or adjusted.
And are there similar concerns for cochlear implants?
Not as much. Surprisingly, the cochlear implant we think of in the vast majority of cases as a one-time deal where the patient undergoes surgery once. The implant stays in, as expected in the vast majority of cases, for a lifetime. And then the outside processor might be upgraded, or the company might, introduce different models, and then that will have to be fit and programmed. But we don't really change the internal component because that would require surgery, and we're never entirely sure if we do a cochlear implant surgery the second time around if it's going to work as well as the first time around. So I think the process is actually maybe a little bit simpler in that regard for patients with cochlear implants.
Okay, interesting. I think we have another question here.
What causes chronic ear infections in children, and how does that possibly affect their hearing over time?
Yeah, that's a good question. I think the most common cause of chronic ear infections in children is fluid that accumulates behind the eardrum. There can be a few reasons for this. The first is that children have immature eustachian tubes. So the eustachian tubes, which connect your ear to your nose, aren't as open and as vertical enough so that any fluid that might accumulate in the ear drains out easily. In addition, the eustachian tube not working well may mean that there's more negative pressure in the ear, and that also leads to accumulation of fluid. So kids get that more often. Kids get fluid in the eardrum more often. That is the most common cause of chronic ear infections in children. Sometimes kids will come to us, especially ones that go in the water a lot, and they'll have chronic outer ear infections, which is a separate issue than fluid behind the eardrum. And that's really more of a mechanical issue of there being wax in the ear canals and there being moisture and the bacteria sort of living there and staying there. But really the main thing that we watch out for in children is middle ear fluid, again, fluid behind the eardrum. Long term, we don't think that affects hearing unless other issues develop, such as, and some of you watching may be familiar with this, things like cholesteatoma or a hole or perforation in the eardrum. Those can be associated with hearing loss that needs to be surgically corrected. In a majority of cases, kids who have fluid in their eardrums end up having normal hearing as adults.
Okay, fantastic. So for people with fluid in the eardrums, it needs to be surgically removed if there is a cholesteatoma. Is that what you're...
Yeah, so exactly. So if there's fluid behind the eardrum, often what we'll do is we will, if there's a hearing loss and or if they have a significant number of ear infections, then we will consider putting in a tube to drain the fluid.
Okay.
If it's temporary, we leave it and we wait for it to go away. So we might wait like 3 months, 6 months to see if it's going away. And if it's not going away and or it's causing hearing loss and or the kids are having lots of infections, then we will choose that. Long term, if in the unlucky cases when that progresses to something like a cholesteatoma, then yes, that may result in a hearing loss that needs to be corrected with surgery. But most kids with ear fluid, again, just to reassure everyone, don't get cholesteatoma and don't have any long-term hearing issues related to the fact that there was fluid once upon a time.
And for kids who are in the water a lot and that causes the ear infection, what is the treatment for that?
Yeah, I think the first is if somebody comes in and they have a really bad ear infection, we have to make sure that infection is gone. No water until that infection is totally gone. Then afterwards, if somebody is super prone to getting ear infections, I think it's also important to keep the ears as dry as possible, going back to the whole earplug thing when swimming or getting in the water.
Okay. Fantastic. And a question came in about sinus infection and hearing loss. Is there a concern there? Also, is that likely to lead to hearing loss in the future?
Yeah, I think that's a great question. So sinus infections are associated with more ear infections, meaning patients with long-term sinus issues can definitely be predisposed to having more ear issues, including fluid behind the eardrum or even ear infections. However, aside from that connection, sinus issues and sinus infections don't directly lead to hearing loss, fortunately. So, for example, if a child just has, sinusitis every now and then, and, if we've seen an ENT and they've said, okay, we don't have to do surgery now, we have to keep on treating it every time it happens, usually, fortunately, that doesn't directly lead to hearing loss. So that's not as immediate of a concern.
Fantastic. Do you know of any advances in the cochlear implant industry coming our way?
I don't think they tell us everything they're working on, but it's gotten better and better. Even in the short time I've been a physician, I guess it's been like 12 years now or however long. Things have definitely improved. Like cochlear implants have gotten smaller, the technology's gotten better. Magnet technology has improved. The cochlear implants all come with a magnet that goes on the inside, which links up to the magnet in the processor that goes on the outside. So even that has improved. So I think things are just improving in general. Signal processing, like how they deal with the sounds coming in and how they generate electrical signals coming out to stimulate the hearing nerve, that's also improving. So I think those are all on the horizon, and it's really a continuous process of improvement. I don't know about any specific things they're working on, though. Maybe they'll share them with us soon.
And we do cochlear implant research here at House Institute as well. So I would encourage you, if you're not already, to sign up to our mailing list, because we always send out emails about, current research, current advancements. Right now, one of our PhD research scientists, John Galvin, he's doing a study on emotional vocalization in children with cochlear implants and trying to kind of improve how they kind of understand their parent through emotion. So that's super exciting. So if you're not on our mailing list, you might be missing out on the next big advancement in cochlear implants. We have another question here. Is an isopropyl alcohol, 94%, a sensible and safe technique to dehydrate the TM and outer ear canal?
Usually, that sounds a little strong. I think for patients with surfer's ear, exostoses, some of those patients will get recurrent ear infections. And we're talking about adults now, not kids, because very rarely will kids get something like that. If an adult has that, sometimes we'll tell them to put in a 50-50 mixture of alcohol and vinegar to basically wash out the ear canal and dry it up. But even then, the alcohol has been cut by basically 50%. And we don't usually use that for kids because even in adults, sometimes that can really sting. So I don't usually recommend putting straight isopropyl alcohol in the ear canal. That can certainly be dangerous, especially if there's an eardrum perforation. So we don't want to just do that willy-nilly. But I don't know if I necessarily recommend that on a routine basis either. Instead, I think in terms of ear canals, the most important thing is don't stick anything in them. There's always a temptation for us to clean our ears. Or our ears might itch, so we might want to stick something in them. But it's that process of scratching the ear canal, sticking something in, or occasionally poking through the eardrum that causes harm. So we usually reiterate to patients as well as to parents of patients, don't stick anything in ear canals. So nothing smaller than your elbow is what we've said for a long time, and that's I think that's actually that goes across cultures and languages. So that expression is used in other languages too.
Fantastic. And speaking of, if you do want to clean your child's ear, is there a recommended way in which you would go about doing that?
I think over-the-counter earwax removal agents are pretty good.
Okay.
So there are lots of drops out there. I think those are fine. Some of them have like a little, almost like a pressurized nozzle, and I think by and large those are safe as long as we know the kid, the patient, the child doesn't have any eardrum issues. But I'd be super careful if somebody has even had ear tubes in the past or has had many ear infections in the past with using something that's pressurized. In general, those drops are fairly safe, earwax removal drops.
Fantastic. Thank you. More questions from the audience?
How much of hearing loss is genetic versus acquired early on? And if it's acquired early on, what are some of the preventable causes of hearing loss that could be addressed?
Yeah, I think modern medicine has come so far in that there is a lot of prenatal testing, including for infectious diseases, meaning when a woman is pregnant, the woman is tested for a variety of conditions, infections that can cause hearing loss that can be present either at birth or it can progress after somebody is born. So I think more and more that leaves congenital hearing loss related to genetic causes as the bigger contributor to hearing loss in kids that are born. I think if the United States, I think there are many good things about the healthcare system here. There is so much testing, even for routine pregnancies, that many of those infections are screened for and treated appropriately. So I think that's super important. I think newborn screening, which is a statewide initiative, and every state has it. Each state does it a little bit differently, but I think newborn screening is also super important. And that, again, is like a huge public health thing that we've really made significant advances in. So I think in terms of prevention, we definitely need to, if it's genetic, unfortunately there's not a whole lot we can do to prevent it. You can always see a genetic counselor to talk about the possibility of a potential child, or having any hearing loss if the parents have hearing loss or if there's a family history of hearing loss. But once we're talking about pregnancy, I think testing is important. And then once the kid comes out, I think testing, screening in the hospital as well as beyond is also super important to catch hearing loss early.
Fantastic. Any other questions?
How do I know if my child is listening to music too loudly?
I know that's tough. I think I think a real rough estimate is if your child can hear you or somebody else talking to them, maybe even if they're not understanding, you completely or even half the words, if they know that somebody's talking to them while they have their headphones on or their earbuds on, I think that's an acceptable volume. If it's at the point where, even with, the headphones on, that they can't hear anything on the outside, that's probably too loud. I know that changes when patients have noise canceling, because that definitely suppresses outside noises. But I think the most important thing is to make sure that everything's in moderation. And there are so many different types of headphones, but if you're able to hear what somebody else is hearing, then it's probably pretty loud for them, depending on the type of headphone or earbud, of course. But that's another just really rough guideline that sometimes we can use.
Fantastic. Thank you. How many days and how should you use deeprocks for kids?
Yeah, deeprocks is one of those earwax removal agents that I talked about earlier. I would use it probably once every couple of weeks or once every 3 or 4 weeks. I think that's enough for most kids as well as for most adult patients. I don't think you can do it more than that, and I don't think it'll cause any harm. But I don't think it's necessary to do it much more frequently than that. The thought of behind using deeprocks consistently is that if you're doing it every few weeks, it softens up the earwax, and with the moisture or the temperature or humidity of the shower, or even just the water sort of going in, that's going to help the earwax come out. So that's a very natural, gentle way of gradually reducing the earwax or keeping it at bay. So I would just tell patients, just maybe once every couple weeks, 3 weeks, 4 weeks, as many drops as the bottle says. Usually it's like 2 or 3 drops should be sufficient. So.
Fantastic. And we've got kind of a fun question. Why do you like working with children?
I think it's super rewarding working with children in terms of, because hearing loss, I think, can potentially be something that really impacts somebody's lives. I think it's rewarding to really be able to make an impact in that sense early on. Kids are cute, and I think kids want to get better too, and I think that's really refreshing sometimes compared to some of the other conditions that we see that are less treatable, or some other conditions that we see that might have a poorer prognosis. So I think that's also another plus. But I think the bottom line is, kids are fun to work with. Kids cheer us all up. I think the vast majority of us can agree about that, and so I think that's a really fun thing.
Fantastic. Thank you. Any more questions from the audience?
I see one just popping up here. It's is it better for kids to use headphones versus earbuds? No, I think either way, they can both be used safely, and they can unfortunately both also be used as if they're too loud, they can be harmful. So I don't know if one's better than another. I think noise canceling technology is getting more and more accessible. I remember even when I was in college, there were, it was like really hard to find noise canceling headsets, and they were like super expensive. Whereas now there are like tons of noise canceling headsets that are relatively reasonable on Amazon, at least way cheaper than they used to be. I think that's a good thing because you don't have to play music or whatever you're listening to as loud to blast it over whatever else is going on in the background. So I think that's a big advancement. But I don't know if one is better than the other. I don't know if earbuds or headphones are necessarily better than the other.
Fantastic. Thank you.
With new kinds of implants on the market, what are they exactly, and which are available to children?
Cochlear, which is the company, this company makes cochlear implants, and that may be what they're best known for, but they have an implant called an Osia, which is spelled O-S-I-A, and that implant, I believe, is FDA approved for patients that are 12 and older. I don't know if that's changed recently, but that was the last I had heard. So that is an option for children and patients with very specific types of hearing loss. Usually it has to be a conductive hearing loss or a hearing loss that we've decided not to address with a cochlear implant. So that's one option. And I don't know if the FDA is going to lower the age on that. They may. I think it's feasible to place it in younger individuals. But as far as I know, that's the current limit. There is another implant made by the company Med-El, which also makes cochlear implants. But this device, similar to the Osia, is not a cochlear implant. And this device that I'm referring to by Med-El is called the Bone Bridge. That's not really available for children yet, as far as I know. I suspect that is also going to change. I do realize that there are physicians that have placed these very successfully in pediatric patients beyond the age specifications that, for example, the FDA may have approved. So I think those are really promising options. I think all of these devices are going to get smaller over time, and I think that's going to be even more attractive for everyone. I think smaller devices mean that when we're talking about implants, there might be less pain, less healing involved, and just from a logistical standpoint, it might be a little bit more convenient. So I think those are the ones on the horizon. There might even be other implants that other companies are developing that they haven't told us yet, and it'd certainly be exciting to look at all those too.
Are there any concerns about implanting a young child and what the pain and recovery is going to look like after that child has undergone the cochlear implant surgery?
Yeah, that's a good question. I think children heal really well, and they heal quickly. In fact, I think they probably heal better than adults on average. So I think that kids actually experience less discomfort after implant surgery as compared to adult patients. So I think by and large, it's not a huge concern. I think the vast majority of children who undergo ear surgery, including implants or surgery for chronic ear infections, which I think are probably the two most common reasons we do ear surgery for kids, can get by with just Tylenol, and some kids don't even necessarily need that. So I think overall it's fortunately not too uncomfortable for the child.
Fantastic. And then we had another question come in here. How often do you need to check to see if ear tubes are in place and working?
Yes, I think probably every 6 months is reasonable. If there are any specific circumstances, sometimes we do it a little bit more frequently. Or sometimes if somebody comes in at 6 months and we see that a tube is almost on its way out, then we'll say, maybe come back in a couple months. Let's check to see if it's totally out then and if we need to put a new one in. But I think just as a general rule, I think every 6 months or even every year, once we've gotten a handle of how stable these ear tubes are, is reasonable. And we can always see patients more often if anyone prefers. But I think ear tubes are fortunately so low maintenance that a lot of the time people don't really have any ongoing issues in terms of having to come in and get them checked out or anything done to them. So.
Fantastic. And can you tell us a little bit more about medical risks like meningitis and the vaccination requirement for cochlear implant surgery?
Yes, so even though there is a meningitis vaccine out there, the main meningitis risk for patients with cochlear implants is from Streptococcus pneumoniae, which is also called pneumococcus, which is the bacteria that causes pneumonia. So what happens for all cochlear implant recipients before surgery, we give them a pneumonia shot. And that actually changed earlier this year in terms of the exact vaccination that we give. So often we'll just give what's called, I think it's the PCV20 vaccine now, and just one shot is enough. So we're not vaccinating against the typical meningitis bugs that we might vaccinate a high schooler or in the past military personnel or college students for. Rather, we're really vaccinating against the pneumonia shot. The risk of meningitis is extremely low with having a cochlear implant. It's just that the risk is still higher than the general population. But we're talking about like fractions, very small fractions of 1% over a lifetime for having meningitis if you have a cochlear implant.
Okay, fantastic.
I thought of a question, actually. If you had a kid and, I'm just curious, if you had a kid and they like to swim and you want to protect their hearing and any ear issues, what would you tell them? How would you instruct them?
Yeah, I think most of the time our ear canals, I think we've either evolved or have been created such that our ear canals are pretty resilient to infections. So most of the time, no special precautions are necessary. It's only that if the parents notice or the child notices that their ears are uncomfortable or they have ear infections after swimming a lot or like during the summer, that earplugs would be recommended. But fortunately, in general, I think most people don't have to worry about that. Ear canals are pretty hardy and they'll resist infections in most people.
Fantastic. And are there at-home treatments for ear infections, or is this something that you take? Okay.
I think the only at-home treatment would definitely first require contacting your doctor, because I think the main at-home treatment would basically be eardrops. And eardrops are pretty effective for a variety of ear infections, particularly those involving the outer ear, meaning the ear canal, or those involving the eardrum if there is a hole or if a pressure equalization tube is already in the eardrum. If somebody has an ear infection that's under the eardrum, but they've never had an ear tube and their eardrum hasn't perforated, typically that means that they need to take some antibiotics to get better. Most of the time it can be you have to see a doctor and make sure the doctor agrees that it is an ear infection and decides on what type of treatment is necessary. Then after that you get to go home and finish the course of treatment at home, of course. So
Fantastic.
Can you predict, based on the physiology of the ear canal or history of ear infections, for example, if someone is not a good candidate for scuba diving?
I think it's tough to answer. I think there are a couple of nuances to consider. The first is if somebody's going to get trained in scuba diving, if somebody knows that they have a lot of issues clearing their ears, they can consider seeing an ENT first to make sure that there are no abnormalities that already exist in the eardrum. For scuba diving as well as for free diving, possibly even more for free diving, as I understand it. I unfortunately don't do either, but as I understand it, for free diving, one has to be able to clear their ears very readily, and scuba diving too. But if you can't clear your ears that well, then I think you really have to see a doctor and talk about whether or not it's appropriate to be diving at this moment, and if anything else needs to be done beforehand. Sometimes it's as simple as using some decongestants before diving to make sure that your eustachian tubes are in tip-top shape and can equalize pressure. But if you've had ear tubes in the past, or certainly if you've had ear surgery in the past, I think it's super important to see your doctor and talk about the risks of scuba diving and see if it would be something that's appropriate for you.
Fantastic. We have a question here. Knowing that CT scan is done before cochlear implant surgery, what are some of the surprises that surgeons face when doing the surgery?
When we do the surgery, the implant actually passes through a fairly narrow channel that we call the facial recess. And we can see that on the scan, but the exact angulation of where our eyes are looking through the facial recess to where we put in the implant, which is close to the area of the cochlea called the round window, sometimes that can be a little bit deceptive on the scan. And sometimes that view is not as easy as you may have guessed from the CT scan. I think that's probably one of the biggest surprises when doing surgery. In the vast majority of cases, we're able to put in implants in kids and adults just through that standard approach, though. So even though that might require a little bit of extra time or a little bit of extra drilling in terms of moving a little bit of bone here or there to see certain things, I think most of the time we're able to work around it.
Fantastic. Well, we are almost out of time here, but I wanted to throw just one open-ended question at you. If there's anything you want parents of kids who are deaf or hard of hearing, or maybe deaf or hard of hearing, if there's one thing that you would want them to know, what would that be?
I think kids are really smart, and I think sometimes they're smarter than we might even give them credit for. I think it's important for all of us to, listen to the kids, and if the kid says, oh, I think my hearing's not as good, then we definitely pay attention to that. And so sometimes as a parent, we might be a little dismissive of what our kids are saying, perhaps. But no, I think kids are really smart and really with it. So I think that's something to keep in mind.
Fantastic. Thank you so much. Before I wrap up here, I do also want to let everybody know that we are coming out with a brand new issue of our magazine, House Calls Magazine, this spring. It's dropping in around 3 weeks, and the issue is all about children's hearing health. We've got a sneak peek on our emotional vocalization in cochlear implant kids, that study that's being done by Dr. Galvin. We've got exciting news about the grand opening of the Children's Center. We've got some really interesting articles in there about global health projects that we're working on. So definitely, if you're not signed up to learn more or to receive house calls, go to hifla.org and sign up today. Join our mailing list so that you can stay on top of the news that we have and be notified the next time we do another Ask Me Anything. And again, I will just like to encourage you, if you have a child or are expecting a child and think that you might want to make an appointment with the lovely Dr. Peng or any of our audiologists or any of the other services that the House Children's Hearing Center will have as it opens this summer, click the link in the description box, hifla.acpage.com/HCHC. That's going to take you to a sign-up form, and somebody from the House Children's Hearing Center will contact you and get you on that waiting list to come in and see our neurotologists or audiologists and all of that wonderful stuff. Also, we are a nonprofit organization, and being able to have Dr. Peng here and being able to see, children, being able to kind of some of the services that we even provide, it really is funded by you guys. So we have a link on the screen, hifla.org/children. You can go to hifla.org/children and donate today. Any amount helps us to continue our mission, helps Dr. Peng as he does his research studies, help us to do our humanitarian efforts where we go to other countries and kind of help provide for other people in other countries, and helps us to do things like this, an educational event where Dr. Peng can be here and answer all of your questions. So I just want to say thank you again for everybody who came and had their questions answered. If you didn't have your question answered and you have a burning question, you can always email hello@hifla.org, and I will forward it along to Dr. Peng and get his answer for you guys. Thank you guys all so much
for
coming.
Tuning in.
Thank you, and we'll see you next